Welcome everyone to our last ISM Glomcom joint seminar of the year. It's my pleasure to be the moderator today. So it's my pleasure today to, sorry about this. It's my pleasure today to introduce our speakers today. So in the first place, we have one of our members of ISM Renal Pathology Working Group, is Dr. Eva Honsova. He's going to speak about amyloidosis, not apolipoprotein. I apologize for this. We have two guest speakers as well, Professor Romana Rysava, and our last speaker for today is Dr. Jakub Sikora.
Yeah, thank you.
So the floor is all yours. Thank you so much. Please, everyone, send us your questions to the chat, and I hope we will have many questions and comments at the end.
Thank you, Carmen. Can you hear me? It's okay. And can you see the slides?
Yes.
Yeah?
Yes,
yeah, okay.
Yes, we do. Yes.
So, thank you very much that we can share with you our long-term story. And this started more than 20 years ago. And as you know, at that time, many things were different. For example, we couldn't share the system for laboratory and clinical data. And in those days, I was asked for a second opinion on a biopsy sample from gastric resection due to pyloric stenosis of a 58-year-old man. And the reason for clinician asked me to do that was because there were deposits of amyloid, and this amyloid were classified as AA type. However, the patient do not suffer any inflammatory disease. And moreover, there were a family history of amyloidosis, where both her mother and sister died of kidney disease, and his sister very young at age 24 after giving birth. And patient's medical history included gout treated for 8 years, and he also underwent partial right kidney resection for renal carcinoma 3 years ago. And after this surgery, he showed rapid deterioration of kidney function and was dependent on chronic dialysis. We were a kidney biopsy for carcinoma, but no other kidney disease was mentioned in the diagnostic conclusion. And here you can see the sample from gastric resection, where in the mucosa and submucosa there were deposits of AA amyloid in immunohistochemistry detection. And it was the variable presentation of that deposits. Some of areas where deposits were massive, and in some other there were only little deposits in vessel walls, and also in the muscularis mucosae there were very low number of deposits in the vessels. The post-operative course of after the surgery was complicated by sepsis with multi-organ failure, and the patient died 2 weeks after surgery. And here you can see the autopsy samples, and all organs which were evaluated were involved. And here you can see the kidney with massive deposition of amyloid in the glomeruli and also in the interstitium and in the vessels. Also in spleen, there were massive deposits of amyloid, and here in GIT location, the majority of deposits were in the vessel walls. AA amyloidosis represents the first type of amyloidosis ever described, and the first case suggestive of amyloidosis was published in 17th century. And because we are from the Czech Republic, I would like to mention Karel Rokitansky. He was born in Hradec Králové, now in the Czech Republic, and spent his productive life in Vienna, now in Austria, but at that time it was Habsburg monarchy. And he described a series of autopsies of patients who suffered from tuberculosis or syphilis, and and developed hepatomegaly, and in their liver there were so-called gelatinous